All right. So, for those involved, today we're going to take a slightly different topic now. This is looking at prognosis. What happens in the future is called prognosis. And if you have one study of prognosis, you can combine many of them together, and that's called a systematic review of prognosis. So, I'm just going to take part one today, and we'll take part two tomorrow. So, in the event of time, I'll just take a shorter session today, a little longer session next time. So this is just a joke. It's a cartoon from R.K. Lakshman. So looking at people predicting the market, and then imaginary market is going up, and try to make a hole in the roof to show that. So what's going to happen in the future is often difficult to predict, and sometimes it's a bit ridiculous when we try to predict things. This to make to acknowledge that this is Cochrane India CMC Vellore affiliate has the clinical epidemiology unit. That's Dr. Vignesh there. And we also have the biostatistics department and Cochrane and the clinical epi unit. So it's a combination of all these activities. That's Dr. Mohan Kamal there. And Professor Prasanna Samya is also there. So just a small story. I had an uncle who fell down recently, and he had hypertension, and he had ischemic heart disease. So he actually came to the emergency department in CMC, and the emergency doctor said possibly a TIA, and he had a CT and MRI, and they looked normal, and they said it's a potential transient ischemic attack. And because he had some high risk features, they decided to admit him. But it's a true story, actually. You could have discharged him as well. So the MRI was normal, possible transient ischemic attack. What's going to happen to him? That's the question which we had on our mind. And we also know that transient ischemic attack, time is brain. Faster you do something like time is heart, how time will become brain as well. And what is the prognosis? So this is just a cartoon to say that, what is the prognosis? And you have the vulture also sitting on top of the patient. And doesn't look good for. So at this moment in May 2025, there was a systematic review of the long-term risk of stroke after a transient ischemic attack. So I thought, oh, this is a good place to look at the systematic review. And this is the final results of a systematic review. So this is time on the x-axis, and this is the cumulative incidence of getting a stroke. So you had a transient ischemic attack at time 0. What's going to happen in the 10-year follow-up? This is data from the systematic review, not one study, but many studies put together. At 1 year, the risk of a transient ischemic attack is, stroke, 5.9%. At 5 years, it's 12.9%. And at 10 years, it's about 19.9%. So the risk of stroke after transient ischemic attack gradually increases. So this is the overview of this. I'm going to teach you how to critically appraise this systematic review. Right. So in today's talk, I'm going to talk more about what is cohort, what is prognosis, and the part two will do the critical appraisal part. So today's talk is more about what is cohort study. Now, in a cohort study, just imagine a group of people in a train. If you look at the metro in Bombay, it's supposed to look like this. I've traveled in one once, it's actually this crowded. So imagine you begin with a cohort. These are subjects who have something in common. What do they have in common? Overcrowded train. Then there's an exposure or a risk factor, that is diabetes. And another group of people don't have a risk factor or don't have diabetes. And then you have to have time. Some time has to go from this. Some are diabetic, some are non-diabetic, and you follow them up over time. I'm just showing this hourglass to show that time is going on. And then the disease of interest here is tuberculosis. This is just an AI image of TB in the lungs. So some people with diabetes who started off this cohort developed diabetic TB, and some didn't get it. And some non-exposed, so means non-diabetic in these crowded train travelers, some of them developed TB, some didn't get TB. So this is the basic anatomy of a cohort study, how one does a cohort study. So then, what is a model? Let us say you have 1,000 people, and you say that yes, diabetes is a risk factor for developing tuberculosis in people who live in overcrowded or who travel in overcrowded trains. But other than diabetes, there may be other risk factors like low BMI or smoking or alcohol. So all that is called a model. If you look at a single risk factor, also model, multiple risk factors also model. That's how one develops and say these are the people that risk develop tuberculosis. Actually, it can be a little bit more complex than that. You take the 1,000 people and divide them into 500, a group of 500 and another group of 500. You develop the model of the first 500 people and you say, yes, these are the factors which are a risk factor for developing tuberculosis, diabetes, smoking, alcohol. Then you see on the other remaining 500 whether this model actually works well. This is called split sample validation or internal validation. Because they came from the same population, you just divided them. Some people divide 70, 30, that's your choice. And then they say, okay, but now I only have the same 1,000. How do I know it will work on somebody else? One statistical technique is called bootstrapping, where, for example, you have 1,000 people. You remove one, it becomes 999. That's an imaginary new cohort of people. You put that one person back, you take another person out. Then you can take, like that, you have 1,000 variations. Then you can take two patients out. So that's called bootstrapping. Some people think it's a silly technique, but statisticians do this. It's a bootstrapping model also shows. So this is one method of developing a model. Another method of developing a model is you have 1,000 people and you have an internal validation. You take the first 250 people and then you have the rest 250 to 700 people. On the 750 people, you develop a model and then you internally validate it. This is like a split sample. But the difference is then that model which is now validated on the group itself here, you do an external validation. You take another 1,000 new people and then you validate it. It's called internally, externally validated model. You can have many variations of this, but this is what is the model? To predict prognosis. And it's not a single factor like in the previous story I told, just diabetes. It could be many factors. So this is how one develops a prognostic model. So let's get more detailed. First, you have to describe what are the factors you think are going to cause TB. And that comes from your previous knowledge or from knowledge of biology or physiology. And then you make a list of candidate factors. Here, for example, diabetes is a risk factor, overcrowding, smoking. And then after that, some of these are non-causal. For example, overcrowding directly may not cause TB, but it may contribute. Low BMI may be causal, may be non-causal, meaning just directly. So the prognostic factors could be non-causal or causal. After that, you make a model. The model is internally validated, then the model is externally validated. Yeah. And then you make a clinical decision rule. When the next patient comes in, you just fill in the blanks in a computer program. Smoker, yes, no. Underweight, yes, no. Alcohol, yes, no. Diabetes, yes, no. Then you tell the patient, oh, you have a risk factor for diabetes. Some people go a step further and say, okay, you have risk for getting TB, let me put you on INH prophylaxis. That's another step, but we don't have to go into that detail. Right. So now I'm going to take some time to take you through some Greek and Latin. Greek and Latin just means that some new terms which you might not have heard before. I know Saturday afternoon, just after Eva's excellent presentation, may not be a good time to have new terms to be learned, but let's learn some new terms. Okay, what are predictors? In the story, what is a predictor? In the story of the cohort which I gave you, diabetes is a predictor. Some people also call it covariates, baseline variables, or features. So increasingly, people will use funny terms like this. You can call it anything you want. That's called a predictor. Okay. What is a training data set? The training data set is the initial set that you use. What is a testing data set? The second data set we use to verify the model. What does the word discrimination mean? Discrimination means I follow up people and some people get TB, some don't get. So how well does my model differentiate between those who got TB and didn't? That's a principle called discrimination. What is calibration? Now suppose my model says you have 10% chance of getting TB, you have 20% chance of getting TB, you have 30, 40, 50. And then I can actually correlate that with the actual probability of them getting TB. It's slightly different from discrimination is just yes or no. You will get TB or no. But my model will tell you probability. Your probability is 30, 40, 50, 60. And we can look at the actual probability of what happened to them. So in that is called calibration. So it's like two sides of a coin. One is simply saying yes or no. The other one is saying at what levels of prediction. Maybe at the lower level of prediction you are very good, but at the higher level you're not very good at predicting. That's called calibration. Then the next one, underfitting. Sorry. Underfitting. Now, suppose I say that to develop TB, the only point is diabetes. Diabetes will predict some amount of TB, but there are so many other risk factors for developing TB. So my model only has diabetes. It is an underfitted model, meaning the model will explain some of the risk of getting TB, but not everything. What is overfitting? Suppose I put 700 variables into a model. I will accurately predict in CNC Vellore 99% prediction that you will get TB. But that same 700 item model if I use in St. John's or some other medical college, it will not work well because there's too many variables. That's called overfitting. So the model should not have be too simple and say, yes, this is enough. Nor should it have too many variables. That's called overfitting a model. Apparent performance. Oh, sorry. Okay. Apparent performance is on the first training data set, no? In that I put the model. And the model will work very well because I developed the model from that data. The initial performance itself, if it's bad, then that's a bad level. But the first is called apparent performance. True performance is when I take the model developed on the training data set and try it out on a testing data set for real life. That's a real performance. In real life, what is it true? Or on another data set for which it was not developed. That's called the true performance of a model. Okay. Now, bias. So suppose I told the model is has some errors because correctly we didn't find out. That is called bias. You know, when we do critical appraisal, we're looking for bias, post randomization, allocation. That's called bias. Inherent mistakes in the system. But variance means if you have a large sample size, the data variance or variability becomes less. So if you have a model which is very simple, only diabetes, right? Then the bias becomes very high because there are so many other things which are not there. But the variability is low because I have only one variable in the model. If I take a complex model and have 700 factors, then the bias becomes low because I have to explain everything. But the variability becomes. So these two are alternatives, bias and variance. Internal validation is when I split the original data into two parts and validate it inside itself. Optimism corrected performance. So after I did internal validation, then I said, okay, now after I am a little more tempered in my expectations. Split sample internal validation, you divide the data into two parts, either 50-50 or 70-30, develop it one part and assess it in the second part. Now, when you're doing artificial intelligence, you'll often hear this word K-fold cross validation. So just for an example, I have 1,000 patients. I divided them to 10 parts, 100 each. So I've derived the model from 9 parts and validated on the last 100. Then I'll keep doing this again and again because I got 10 parts. So I'll redivide it on till I'm very sure that the model works very well. This is called K-fold cross validation. Okay. Then you have temporal validation. Temporal validation is, let us say that Reba developed the scoring system during her PG in the last 2 years. And then Rishi comes along and says, I want to validate this now. But he's validating on a future time point. So it's a temporal validation. What was derived earlier is now even applicable at this point of time. Bootstrapping, I already explained in the previous slide what is bootstrapping. Basically, you take off some data and call it a new data set. Internal, external validation also I explained in the previous slide. External validation is on new data. It may be temporarily unrelated or it may be at the same time. That's just the word for external validation. What is penalization? So especially when we have AI, AI will take your name, your age, your gender, your occupation, thousands of data about the individual and try to predict TB. Now the models will struggle, or statistical models will not be able to handle 10,000 predictor variables. So you have to try to shrink the number of variables to a reasonable number of variables to explain the chance of developing TB. So one of that method is called penalization. We need not go into that methodology, but penalization is the method for reducing the complexity of the model. And one such is called a lasso ridge regression. We don't go to explain what is lasso, but we're just trying to say these two become more important when you're doing AI models, when you have, because AI will some data from everywhere about you. You have your Aadhaar number, your PAN number, your income, your parents' income, so many things that you look at, and you can't do a model easily than that. Reproducibility is when I take the performance in a new sample. Let us say that I develop the model for TB in Vellore and I reproduce in another group of patients in Vellore. The next one, transportability, is the model derived in Vellore. Will it work well in Chennai? So this transportable, meaning generalizability, but they also call it that. And generalizability is a word that actually takes both of these into account, reproducibility as well as transportability. So I know it's a bit of a heavy discussion for the morning, but when you do this prognosis, people use these words often. You guys must know that. This is a very good resource. I've taken most of it from here. Cochrane Prognosis Methods Group. All what I'm teaching is freely given there. So there's nothing difficult about it. And that's the website, Cochrane Prognosis Group. So this is just some cartoon. Perhaps we better cut back on our trace elements. So, obviously, it's slowly disappearing. So, okay. So why are we doing this? Why am I taking this talk? For as a postgraduate or a faculty, is it important? Demand from healthcare. So artificial intelligence is now doing supermodels. We can predict anything using AI. Are you going to eat today morning? Are you going to skip lunch? What will you wear today? And then there all these shopping apps also are trying to constantly predict your behavior. New biomarkers are coming out of the woodlands. Every day you go to medicine, there's a biomarker every day. So, and that biomarker is supposedly the best biomarker in the world. So, we need to understand that for that perspective. Secondly, the prognosis, overall prognosis. For example, they have a patient myeloma in the ward. Previously, when I was at PG, there only so beta 2 microglobin. With high, bad prognosis. With low, good prognosis. Now we have every day a new myeloma score is coming out. For pneumonia, there's a new score coming out for the overall disease. Precision-based medicine is not only for everybody, it's for you only. Suppose Akash comes with fever and he's 24 years old and he doesn't have diabetes and he has no family history, what is his risk factor? So precision medicine is also coming up in a thing. So guidelines and health policy also need good quality answers. So for example, your COVID guidelines. They didn't say anything about prognosis. But if there's a systematic review of prognosis in COVID, they're going to incorporate that systematic review in their guidelines. So even for guideline development, you need good systematic reviews of prognosis studies. Now, the one problem is that, again, like systematic reviews in general, in some topics there are more systematic reviews than primary studies. It's because people have got used to the idea of doing systematic review, especially in COVID, people sat a lot at home. And everybody did the same systematic, sometimes there will be 10 systematic reviews on the same topic. So there are good systematic reviews, like you said, garbage in Pamela, that's from garbage systematic review. So we must be very good in critically appraising systematic reviews because nowadays everybody wants systematic reviews to change practice. And if a systematic review is poor, then you're making poor quality decisions. So this is a story. It's from a story called Middlemarch in 1872. And the doctor called Dr. Lithgate. And he says, on prognosticating, diseases of the heart are eminently difficult to perform predictions on. Let's say heart failure. Our more lengthened observation is wanted on the subject. But it's my duty to tell you that death in this disease is often sudden. At the same time, no such results can be predicted. Your condition may be consistent with a tolerably comfortable life for another 15 years or more. This is written really in 1870s for heart failure. Can you imagine? Even now we have some heart failure patients before tomorrow morning get dead. Some guy 15 years later comes and reads you and like, no, doctor, I'm doing very fine. So prognostication is a tough act to do. So this is a thing to consider. So what's the definition of prognosis? It's a relationship between predictors, let's say diabetes, and the outcome, which is TB. Define population. So the population I showed you in the picture, there were people traveling in overcrowded trains. And at the end of it, people with or without disease, the end of it. They should not have disease to begin with. That's an important part of cohort studies. You should have TB to begin with. TB should develop later on. Then only you can have prognosis. So prognostic risk factors. Now this is quite easy. Environmental risk factors, people often forget environmental risk factors. As doctors sometimes mention diabetes, smoking, alcohol. But environmental risk factor could be socio-economic conditions, healthcare access, quality of the healthcare, the climate. Increasingly, climate science has become a big thing. Someone seems to have got into climate science. But it's a big deal actually now, climate and health. Then, of course, your demography, behavior, psychosocial, pre-morbid, biological. Then the disease itself, the outcome could be imaging, pathophysiology, genomics, proteomics, metabolomics. All these could be an interaction which causes disease. Right. Now, I know that we have often in Bayesian analysis for teaching diagnostic, pre-test probability, likelihood ratio, post-test probability. I don't know if you've done it for your group, but that is the same thing actually in medicine. Based on the initial history, we always ask the post that is what's your differential diagnosis. That differential diagnosis gets refined at the end of your physical exam. Then you have a list of differential diagnosis, simple investigations. At the end of simple investigations, you refine your diagnosis some more, and then complex investigation. So this is how generally even prognosis starts getting accumulated. So the strength of the evidence slowly goes up one by one by one. In the end of it, is it established? Yes, diabetes is an established risk factor for TB. Promising means, yeah, it appears that diabetes may be a risk factor. Mutated means I think so, you may not think so. So at the end of the day, we have to come to some conclusion about the risk factors. So what is the scope of prognostic research? Patients may ask, how much utility or value do I place on possible range of adverse prognostic outcomes? Okay, we have a patient with UTI. We're not sure they're going to die or not. This scoring system will predict your death. Hey, is it really very good in predicting my death? Or it's like the score is not so good. Before you make a decision, the patient wants to know how good the score is for their prognostication. What are my chances, doc? Clinician will ask the same thing. For discrimination, does he have TB or not? How can I calibration? Is it 10% chance, 20% chance, 30% chance? Should I change my treatment in the light of prognosis? Hey, if you say the prognosis is very bad, maybe just send him home. Why do you want to waste money on treatment? That's a big decision. So again, prognostic. Basic scientists are asking, what are the molecular and cellular mechanisms leading to poor prognosis? Metabolomics, genomics, proteomics. Healthcare policy makers are asking, should we waste money on this new treatment or should we not? Public policy. So they are also worried about equity, environment, weather, climate. So all these kind of questions one gets why prognosis study should be done. There's two important things: diagnostic studies versus prognostic studies. They may appear very similar, but we actually are quite different. In a diagnostic study, there will be an index test and there will be a gold standard test, usually at the same time. For example, you will be doing Z and test for smear. At the same time, you can do a PCR test, what you will call gold standard, and both at the same time. But in a prognostic study, generally diabetes will be here now and TB will develop later. But sometimes diagnostic study, for example, there's a test for Alzheimer's. The Alzheimer's blood test is there today, but I may develop Alzheimer only clinical Alzheimer's 10 years from now. But that means Alzheimer is already going on now. So I may have to follow up studies. Rarely these kind of diagnostic studies where the gold standard appears a little bit later on. So those are also called diagnostic studies. And therefore, there is a sort of overlap, or people get confused between a diagnostic prediction model and a prognostic prediction model. Here, the diagnosis appears a little bit later, and here the prognosis is always a bit later. So just to keep in mind that because in diagnostic study also people will talk about calibration, discrimination, sensitivity, specificity. All right. So there will be a large number of new cases with TB. Let's say you follow up, one of you go to Bombay. What is she? Are you from Bombay? No, far away from Bombay. And you decide to study patients who develop TB who travel in crowded trains. There may be 1 lakh people who develop TB newly in that, but among that, only about 10,000 will go to the local GP. Among that, GP may miss half of them. Only 5,000 will present to specialist. Among that, only few of the 5,000 will have the TB test done. Among that, some tests may be indeterminate, and a smaller number will actually take treatment. So this is the tip of the iceberg picture. People have got various ideas. So incident cases are here, but the presenting cases to the hospital may be very small. So we'll be very careful to do prognostic study. I will miss a large number of people. I am missing a large group of people because that's a major problem with prognostic studies. So then what are the types of prognostic studies? One is called early exploratory studies, where we don't know, hey, TB is a disease, but nobody knew why people got TB. So let's see whether obesity, whether malnutrition, whether smoking, whether that. It's an exploration. We don't know. For example, when influenza came, what are the risk factors for death in influenza? About 65, diabetes. Young people are generally healthy. Then when COVID came, people didn't know. Oh, the same thing. So initially, about 65 stay inside, diabetes. Then suddenly, that COVID risk factors is slightly different from. So that's the exploratory model initially. So the exploratory model. Second, whether the prognostic factors, you can identify people at low risk and high risk or progression to death. So initially, okay, we just know some factors are there. Then can we say, can it accurately determine low risk or high risk of death? Lastly, can we determine even for COVID, for example, if who are the people who benefit from paracetamol? Maybe everybody who's sick will not benefit from paracetamol. Maybe some particular subgroup or some biomarker will identify people on whom this particular treatment may benefit. And one time for TB meningitis, there was an LT4 genotype, and they said only those people will benefit from steroid. And after some time, they changed the mind. No, that's not so such a great idea. So we're trying to always find subgroups of people who may or may not benefit from treatment. Now, this is just survival of people. 5-year adjusted survival of people. And you'll see that people from Iceland seem to live the longest as compared to people in Czech Republic. This is also a prognostic study, but it's just an overall country-wise, how long do people live? It's one type of prognostic study. It's a fundamental prognostic research, 5-year survival. The second one is people with cancer, HER2 positive, negative versus HER2 positive. What is their survival? This is survival curves, a positive value for HER2. Those with negative have a worse prognosis. So this is a different, it's called prognostic factor research. What is the factor here? The HER2. The HER2 differentiates you from good prognosis to bad prognosis. So initial was just fundamental, just overall prognosis. This is called prognostic factor research. There are two factors or one factor which can differentiate. The third one is called prognostic model research. For example, in general medicine, if somebody comes to ICU, we put in the details of something called Apache score. You know, the postgraduate surveyor will an Apache score. Or a stroke patient. What score do we do? NIHS stroke score. And they end up to tell you good prognosis, medium prognosis, bad prognosis. So this is also called prognostic model. It's a model, multiple factors. It's not just one. This is one factor. The model generally has more than one factor. So this is called prognostic model research. Multiple clinical variables and the risk factor of an endpoint, it is usually death or no death. You can even look at the effectiveness of treatment. And people make decisions based on this. The last one is called stratified medicine research, where predictors of differential treatment response. So if you are ER positive, tamoxifen may work better. If you are ER poor, tamoxifen may work worse. So now the marker or the prognosis of the treatment response is also taken into account. So these are the four major types of prognostic research. Okay, in the interest of time, we'll stop today. Tomorrow, on next Saturday, I'll take an article, that article which I showed you about TIA and risk of stroke. We'll go through some guidelines for prognostic critical appraisal of systematic review, and then we'll go to the article in detail. Yeah, any questions?